Hello and welcome to today's webinar, Validating Triage Competency with Shelley Cohen, our Triage Champion. This is Jenna Pichet, Director of Communications for the Sullivan Group, and your moderator for today's webinar. Before we get started, I have just a few housekeeping announcements for you. If you're having any technical difficulties today, please feel free to use your chat box and send a message to the panelists or the organizers, and we'll try to help you answer your questions there. We will also have a question and answer period following today's presentation, but you're more than welcome to chat your questions at any time during today's presentation. Again, you can use the chat box and send those to organizers and panelists, or the questions box to submit those questions at any time during today's presentation, and we will get to those following the core of our content. So with that, I would like to introduce Brant Roth, Chief Marketing Officer and VP of Business Development with the Sullivan Group, to get us started. Brant, the floor is yours.
Thank you, Jenna, and thank you, Shelley, for joining, and everyone else on the phone today. Next slide, please, Shelley. Before we turn it over to Shelley to talk about the subject of today, we wanted to provide a brief background on the Sullivan Group and our relationship with Shelley in delivering our online triage programs. So next slide, please, Shelley. The Sullivan Group, for those that aren't terribly familiar with our organization, we were actually started about 20 years ago by an emergency physician, Dr. Dan Sullivan, who also has a legal background. And Dan has been studying medical legal issues and malpractice lawsuits for over the past couple decades and done a lot of national lecturing for American College of Emergency Physicians. Our focus at the Sullivan Group is primarily on how do we change clinical practice and improve patient safety and also reduce liability and exposure to litigation. Fortunately, over the last 20 years, we've been able to work with a number of different hospitals where we have a pretty large footprint across the country with 900 acute care facilities, and we're impacting north of 20 million patient visits annually with our online platform. Next slide, please. At this point, our platform actually covers the entire spectrum, although we are rooted in emergency medicine, and that was the genesis of our company. And we have now expanded our platform and our offering to cover all different areas of healthcare, whether that be in the ambulatory world or in our hospital-based acute care settings, and we have programs for that. Or we have programs that are more tailored towards specific initiatives that hospitals may be struggling with: physician integration, patient satisfaction, medical legal essentials, patient safety fundamentals. So a number of different topics and areas where clients will identify one particular initiative that they may want to utilize some of our platform to augment any sort of existing initiative, or perhaps use our entire program. For example, in our triage setting, we have a program in triage that organizations will use for competency, both the online education and the online assessment. So if anyone has any questions about this, we're happy to have a conversation about that after the webinar. Next slide, please. And really, this is largely built, the platform, the content experts that generate the materials and the solutions that we deliver to the client base is largely from this risk collaborative, the Risk Safety Quality Collaborative. There's a group of about 25 clinicians across the country that of all different specialties and disciplines of medicine, or even we do have a few non-clinicians that contribute to this collaborative as well. But if you'll notice in the bottom right corner, we have Shelley Cohen. She's part of our RSQ collaborative, and through our work and through our relationship together, we actually were able to build a triage program that focuses on triage competency, improving critical thinking skills for the nursing community. And there are about 200 hospitals that are using that program currently, and we've had well over 100,000 online modules taken with great feedback from the online courses and the online assessment. So with that said, I'll turn it over to Shelley, and she can do an introduction and jump into the material at hand. So Shelley, floor is yours.
Thank you, Brant, and thank you, Jenna. Hi, everybody. I appreciate you making time for the program today and talk about good timing with the ENA just releasing this week their updated position statement on triage competency and qualifications. We are going to be addressing part of that in our discussion today. This is just such perfect timing. And as Brant mentioned, I've been working in the collaborative with the Sullivan Group for about 6 years now. I still actively practice 1 to 2 shifts a week in the ED at Williamson Medical Center here in Franklin, Tennessee, and have authored several books particularly focused on critical thinking skills. So focusing on what we're going to be talking about today, it's all about how do you validate that staff are competent to do triage. And it's interesting how we look at validating competency for skills such as ACLS or PALS or now our TNCC qualifications for trauma. We need to start applying some of those similar processes and thinking in how we actually do this validation process. So to begin the discussion, we really need to make sure that people understand how to define the term competency and how is that really different than education. And sometimes we intertwine the word skills, education, and competency when in fact they each have their own individual meaning. And it's very important to delineate these differences. Donnellan talks about competency being the review and documentation of an individual's demonstrated ability to achieve the job expectations stated in his or her job description. And I think this is one of the best definitions I've seen out there about the term competency. So this is a focus on that nurse's ability to demonstrate their skill related to triage. If we then compare that term to training, we're now looking at a knowledge piece. You know, we talk off and on with this term, how do we fill the knowledge gap? And filling the knowledge gap is the education piece that we talk about, or sometimes we call it, we have a training session on how to use our new pumps. But whether or not staff can actually apply that education and use the pumps in real time, that's the key piece related to competency. So looking at the difference between the two, knowledge is simply an understanding of information, awareness of facts, whereas competence is the ability to display the ability, the skill, and the aptitude related to that knowledge that we have filled. So when you're developing your ongoing and initial competency packets for triage education, triage competency, it's important that you teach staff that they understand just because they attended a class on triage or took an online course on triage does not imply that they're actually competent to perform the skill of triage. What we've done is we've filled that knowledge gap piece, and now today we're going to talk more about how do we then validate that competency piece from there, taking it to that next step. A lot of facilities have different methods of filling that knowledge gap. We have the live education tools that a lot of people use. We have online learning, individual self-study. There's a variety of methods that can be used to fill that knowledge gap related to triage. It's very important that managers, educators, and the staff understand the professional and regulatory responsibilities in this topic. So from the American Nurses Association, the public has a right to expect registered nurses to demonstrate professional competence throughout their careers. They also talk about the fact that the competency process should have meaning, promote critical thinking and learning, and be engaging for the staff. In the 2015 updated scope and standards of practice from ANA, they've also included the following sentence: an expected and measurable level of nursing performance that integrates knowledge, skills, ability, and judgment based on established scientific knowledge and expectations for nursing practice. And this is part of their definitions and expectations related to nursing competency. So you can see just from the American Nurses Association, we have these expectations that have been set. I think the real question is, how do we actually measure triage competency? Trying to determine, is this person, qualified and competent to triage? If I move to another state, just because I've been doing triage where I am now for 10 years in no way implies that I'm competent to now perform it at a different facility that may have different processes for triage or triage policies and practices. So we've got to be able to measure somehow this competency level. And we start by first defining, well, who's really competent to triage to begin with. And there are 4 bullets that I'll look at when I talk about triage competency. The first being legal requirements. So in each state's Board of Nursing, there is a legal requirement to have your RN license to perform a patient assessment. And triage is clearly a patient assessment. The second bullet or element for triage competency in deciding who is competent is what is your hospital policy or hospital job expectations defined. And this is a good time to go back and look at those resources to make sure they actually match the reality of who you're assigning to triage. The third bullet item is certifications. Many facilities require the nurse at triage to have a current ACLS, PALS, TNCC. Some facilities require their CEN, Certification in Emergency Nursing. And that fourth bullet, defining who's competent to triage, has to do with experience. For example, do you believe that a registered nurse should have at least 1 year experience as an ED nurse before they are deemed competent to even attend the triage class and go through the competency validation processes that we'll be talking about? So those are the 4 key bullet points you need to go back and start with, and making sure these are clearly defined in job descriptions or in your triage policies and procedures. In 2012, the Emergency Nurses Association updated their scope and standards of practice. And here it really defines for us what we're determining what that triage nurse is able to do regarding at scope of practice as well as the practice standard. And we're going to look at several items that come from these practice standards throughout our program today. If you do not have a current copy of the 2012 Emergency Nursing Scope and Standards of Practice, I highly recommend you retrieve a copy. You can get it on the ENA.org website, and there's a whole section in there related to triage. Well, last week, the ENA rolled out an updated version of their position statement on triage qualifications and competency. The last one they had done was actually released back in 2011. And the link is there where you can actually download this 4-page document. And if you don't have access to the link, you can just go to ENA.org and search for it on their new website. So I want to take a look at a couple of key points that have been made in the updated version. Now, a lot of the content is very similar to 2011. However, there is a greater emphasis on retrospective chart review to validate triage competency, which we'll be talking about in the second half of the presentation today. So in the updated position statement, let's take a look at the slide here. It talks about the process of triage is best carried out by registered nurses and nurse practitioners with emergency nursing expertise who have completed a triage-specific education program. The updated position statement from ENA also talks about the fact that competency is an ongoing validation process, and it's part of safe practice in the ED. One of the things we tend to do in our profession is we deem somebody was competent in 2001, and they've worked with us for 16 years, now it's 2017, and we make an assumption, well, if we got them checked off in 2001, they should still be really good at this, right? I haven't heard anything bad from anybody, and we can no longer practice that way. It is not considered safe practice. There has to be a process for ongoing validation. The position statement also talks about the fact that validating this competency needs to include observation and chart review to ensure accurate clinical decision making. It's all about the ability to apply, whether you're using ESI or CTAS for your triage scoring systems. Does that triage nurse use the scoring system correctly? Are they making a good and accurate clinical decision with their patients? Well, a little bit back to the ENA scope and standards of practice. Remember, I mentioned in that document from 2011, there is a whole section on triage. And I want to just refer to a few items that they note there related to the triage standards and competency. The emergency registered nurse triages each healthcare consumer considering these 3 bullets now: utilizing age, adjusting for developmentally appropriate, and using culturally sensitive practices. Using all 3 of those elements now to prioritize and optimize healthcare consumer flow, expediting those healthcare consumers who require immediate care. Can they make that rapid decision? So does your current triage competency process address these 3 elements here on this slide? If not, I recommend you go back and review what you have written in your document for competency process for triage or in your triage policies and procedures. When we talk about triage competency and why it's essential, people hear me talk a lot about triage is risky business, and it truly is. When you think about it, every single patient, whether they walk in, get dropped at the back door, or come in by EMS, however they appear, they are all triaged. So it is, in fact, the most frequently performed nursing skill that's done in the ED setting. And it is a high-risk skill. We're asking people to make some very rapid decisions in a very sometimes chaotic environment. And it also requires an astute knowledge of age and disease specifics. From the scope and practice standards, again from ENA, rapid, efficient triage and judicious care contribute to optimal healthcare consumer outcomes. When you're at a point that you're ready to revitalize your current triage competency, qualifications, documents, and process, these are the types of statements that I recommend you use so that staff can better understand why they need to be held more accountable for validating ongoing triage competency. Some of you may have heard of Donna Wright. She is who I call the competency guru for healthcare, and all of her writings are of great support and resource, and I highly recommend that you utilize her most current book on healthcare competency. And she talks about 3 domains of competency that I want to address here and integrate these directly with validating triage competency. They are technical, critical thinking, and interpersonal. So what we're going to do now in the next few slides is we're going to take each of these 3 domains and apply them very specifically to triage competency. So starting with technical, 3 questions to ask. Are the current triage levels being assigned correct? And the only way you're going to know that is through retrospective chart review. Are standing orders and your protocols for nursing protocols, are they being followed? And again, the only way you're going to know that is to retrospectively do a review. And finally, under the technical domain, is documentation accurate and complete? And because we don't have somebody sitting with the triage nurse all the time doing direct observation, it's imperative for everybody to understand the importance of retrospective chart review. So this is our first domain of competency, technical. The second domain for competency is critical thinking. And again, these are all based from Donna Wright. So let's apply this specifically to triage. Are common red flags rapidly identified? Does the nurse apply lessons from previous events? And does the nurse connect risk factors to presentation? So does the nurse connect the fact that somebody who has abdominal pain but also has a significant risk factor because they're on an anticoagulant, do they make that connection when they do their critical thinking decision? And the third and final domain of competency is interpersonal. Does that triage nurse effectively communicate with their team leader or charge nurse? Does that triage nurse demonstrate respect for the diverse patient populations that you all serve? And finally, does that triage nurse manage angry or aggressive patients, or possibly the family, safely, efficiently, and effectively? So each of these three domains of competency must be addressed in your triage process for validating competency. And I have to say, I love this cartoon because many a day you will find me sitting like this in the ER wondering, what is this person on the other end talking about? And we have so many struggles sometimes with our inability to effectively communicate, or we're being expected to communicate with the person on the other end that's not doing possibly a very good job of communicating. It can be frustrating for sure. Staff input is absolutely essential and absolutely critical. And you'll see in this picture here some of the folks that I work with in our ED, and I recommend tremendous effort is made to gather input from staff related to whatever you're going to put together for your retrospective chart review requirements, your triage education, or both of those. So have staff get engaged. Let them assist in designing what the competencies for triage are going to look like. Educate them on the different methods of how you validate competency, which we're going to be talking about today, and really get them engaged through this process of ownership, which is going to be very important as you work on improving your triage processes. One of the things you're going to find when you up the game for triage competency and qualifications, you will also find improvements in triage practices. One of the ways you can engage staff, for example, is doing a very informal survey, such as, I'd like to see the following included in our annual triage competencies. And you can use the bullet items there, or items you come up with or staff come up with. But I think a survey process is very helpful in this scenario. Let's take a look at some common staff perspectives, and these are things I hear all over the country. The accents may be a little bit different, but all the comments really seem to be the same. So let's look at the first one. Mary said he was off orientation and ready for triage. You've got to be kidding me, really? He still doesn't even know how to assign a triage level for the tracking board. The next one, please do not put her out at triage again. Remember how backed up things got yesterday? And finally, this is the third complaint from a patient about her being rude at triage. How does that still make her competent? When you hear these types of conversations in the background, it is a major red flag that the competency issue and triage qualification piece needs some direct attention. We're going to share at this point different methods you can use to validate triage competency. Some of these you'll be familiar with, I'm sure. So you have the written method. You can do this after they've sat through a class on triage or done an online course that includes questions, or a separate online learning activity that is nothing more than a written exam. Observation, we call this real time, but observation can also be a simulation experience, and sometimes it can be a computer program. A third example is a case study or a scenario. You can do a packet of scenarios or case studies during an actual class. You can do it after a class. You could do that every other year as part of your ongoing validation for triage competency. Let's look at a few other methods for validation. An exemplar, you can do a group discussion, my greatest triage challenge and what that was, and what level did you assign, and how did you come up with that? Peer review is another method of validation. So if you get to the point that you're ready for retrospective chart reviews, those can be done as a self-review and a peer review process as well. We'll talk in more detail about those in just a little bit. And finally, self-assessment. It's very interesting when we let staff do a self-assessment and review of their triage decisions, and then compare that to a peer person or the manager or the educator looking at the same triage. That really highlights some gaps that need to be filled from an education perspective. So in summary, you have lots of different opportunities for verifying triage competency. You can mix these up quarterly. You can change them out every other year. The idea is that you understand that there are more than one options for validating competency. Now, this is really interesting. This was a publication by Jordy in the Scandinavian Journal of Trauma. And what they did was they took nurses that did triage at 4 different hospitals, and they were using ESI. And they gave them 30 teaching case scenario examples for triage patients. So 69 nurses were included in the study, and only 59.6% of those 30 case scenarios were correctly assigned a triage level. What was very interesting, though, is that 78% of those nurses felt confident in their ability to use and apply the ESI scoring system. So one of the conclusions from this study actually was using standard written case scenarios to determine using ESI scoring effectiveness correctly may not be the optimum means to rate a nurse's triage skills. And there's other studies that have been released that are really interesting and some are concerning. You know, when people perceive they're doing a really good job with something and we retrospectively look back and it reveals that their perceptions just don't line up with reality, it typically is related to a knowledge gap. I think it's really helpful to have a plan. So if you're looking at a plan for this year or for next year in your triage competency requirements, I recommend you balance this out with a novice nurse, the new hire nurse who's experienced from elsewhere, and your current staff. And if we take a look at this chart, we're looking at different requirements. Their license to practice as an RN, how much experience, did they take a triage class, what about chart reviews, and how are we validating their competency? And you can go through this and notice there's a few differences between, for example, a novice nurse versus your current staff. And when you have a plan like this outlined for this year and the following year, staff know very well up front what to expect that they're going to have to bring to the table to validate triage competency. So I think having something like this is very, very helpful in planning. And it's very specific and detailed. You've probably heard this statement before that triage is a process, it is not a place. And although somebody may not be assigned triage out front, for example, every patient coming in by EMS still is getting triage. Every patient being dumped off the back of a pickup truck on your back door is still getting triage. So you need to make sure you've clearly identified which nurses should have this competency validated, not just people assigned to a triage desk up front. When we're looking at determining the nurses that are going to be required to use these triage skills, it's very important to remember triage is all about sorting, trying to get that rapid identification of who has the greatest potential for demise, and what is it about this patient that separates them from the rest of the patients that are in the lineup here waiting to be seen. Now, one of the ways that you can help patients and staff and your outcomes related to triage is the following. I recommend you look at your top most frequent primary diagnoses, not reasons patients came to the ED, but the actual discharge or admitting diagnoses. The ones on your screen here are the most current from CDC, from EDs across the country. And look at the top 5. And then go back and look at those triage notes and take a look at what does or does not match up. And this is a great exercise for staff to go back and look at. Doesn't mean the nurse may have made a mistake at triage with their decision, but I think it's a reminder that just because the patient came in with abdominal pain doesn't mean that they're not having an MI. And did that get missed because the nurse didn't see this atypical female 82-year-old patient that was having an MI and their presentation was abdominal pain. So it's very important to make that connection. You know, we look at big sporting events and sit back and say, once we've seen it in slow motion, oh, I never would have made that call. You know, quarterbacking after the fact is really easy. And it's not always easy to be the one to figure out who's next. You know, who came first, the chicken or the egg? And if you look at this cartoon in front of you, one of the things that's very deceiving at triage is when a patient comes in with their arm in a sling and you are backed up at triage, overloaded, already checking your own pulse because you're stressed out, it's so easy to assume the reason the chicken's here is because they got an arm problem. Well, that arm injury could be a week old and maybe they're here with crushing chest pain. And if you don't ask the question, what brought you here, how are you going to know? So I really like this cartoon. It's a real important reinforcer of making sure that the triage staff do not make assumptions. When we make assumptions at triage, that takes us down that path of bad outcomes. Some of you may have heard this term going around. It's called triage, because we have so many patients in EDs of all different sizes across the country being assigned patients with a level 3 is becoming the top level being assigned at triage. And when we go back and look at some of those records in different facilities, what we find is a lot of those level 3s should have been a 2, and some of those level 3s could have been a 4. So it's also important to look at what percent of your patients, and now that most of us are computerized, you should be able to pull this report through IT, what percent of your patients are a level 1, 2, 3, 4, and 5, and then randomly pull some of those charts to determine maybe we really are seeing more level 2s than we thought, and it's just the problem that the level 3s were miscorrectly assigned. A lot of you based your acuity, requirements for staffing, and other needs in your department when you validate what percent of patients you see at a very high acuity, level 1 or 2. And if staff are not assigning the correct triage level upon entry, this in fact can impact many things, including financial, your budget, and requests for equipment, as well as for staffing. Triage is all about the flow, and assessing your patients is an ongoing tool, just like competency assessment has to be an ongoing process. And we need to have this competency assessment process be really responsive to our changing environment. Some of you may have moved from this comprehensive triage to a more rapid triage in 60 seconds or 2 minutes. And we need to make sure that our assessments for validating triage competency really reflect what you're currently doing and what you currently expect from staff. What I've done for you in this part of the program, I've broken down for you what I call the actual essentials of triage competency. So we're going to begin with essential number 1. I want you to define in writing what your competency requirements are for the new grad, that experienced new hire, and your current seasoned staff. And that takes us back to the chart you saw in the previous slide. In your initial triage competency, you want to think about what is it they're required to do in their job the first 6 months that they're working in your department. What are some of the high-risk accountabilities they're going to be engaged in those first 6 months? And what are the core job functions that you're expecting of staff when you hire them initially? I think if you can answer those questions, it can help you determine when it's appropriate to begin the triage education, especially for that novice nurse. When we compare this to ongoing triage competency, we need to make sure we look at the changing nature of the job. And again, we just talked about, have you gone from comprehensive triage to a more rapid triage assessment? We have to look at changing skill sets. Have the screens required for triage documentation changed, and are staff complying with those documentation requirements? And whatever you decide to do for your ongoing triage competency, keep it achievable. You know, there's lots of things we all wish we could do, Oh my goodness, it would be great if we could do A, B, and C, but reality check sets in and we realize we can't do all three of those. So make sure you do keep it achievable. In essential number 2, we want to make sure we assess all the areas related to triage. Now I'm going to take you back to the beginning of the program, Donna writes domains for competency. Make sure you address the technical and clinical skills related to triage. Make sure you address and assess the critical thinking aspects of triage. And finally, those interpersonal skills. In essential number 3, I recommend you develop a written process for people who cannot complete the triage competency requirements for a variety of reasons. What are the remediation options going to be? Is there really an option for a change of assignment? Because if you say, we just won't put her out front anymore, we'll let her work in the back, but you still let her triage ambulance patients, how have you in effect made things any safer? And looking again at patient outcomes. And what I have found is a lot of facilities do triage education. Some of them even look at retrospective chart reviews, but most do not have a set remediation process in place. This is really important to develop. This is something else as an example for initial triage competency that I developed so you could take a look at this. Now your red exclamation point means stop, you need to make a decision. It's called a decision point. So for that new graduate, new hire, they should complete probationary period in their general ED orientation. Do not put time and money into triage education until they've completed this process. The next step is, can they successfully complete the formal triage education that you require? There should be a 6-month performance assessment evaluation. And there needs to be a timeline plan for that direct observation out at triage that's typically done by their preceptor. Compare this now to ongoing triage competency, where we're going to have more retrospective chart reviews, direct observation. You might do staff meeting case presentations, a case scenario packet, maybe a triage update class. That's a 60-minute class, and you do a written knowledge assessment. And certainly always consider patient and peer feedback when you're determining ongoing triage competency. One of the things that you will need to do when you start working on ongoing triage competency initiatives, you're going to have to prioritize them. There are some things that you may want to do, but you realistically can't get to them till next year. So once you've identified all the initiatives you want to have for competency for triage, you will want to start looking at prioritizing them. And that will help you develop your calendar for next year. So in your prioritizing these initiatives, you want to look particularly at these 3 items: new triage policies, new triage processes, and any high-risk triage concerns. For example, have 3 different nurses missed at triage high-risk patients that presented that were testicular torsion. So that would be a high-risk concern that you would want to address as a priority for your triage competency validation. Some additional initiative questions to think about. Are there some age-specific concerns? Is there new equipment in triage? Was there a near miss or a bad outcome that needs to be reviewed? And not from a punitive measure, but to re-educate people. Were there any revealing details from a patient survey? And are there new documentation requirements from a regulatory perspective or from your state requirements from CMS, Joint Commission, or ENA, for example? If you look at this diagram here in the center, we have triage competency, and we're looking at the elements of your triage competency program surrounding them. Starting at the top, what are you going to do at that point of hire? You need to be flexible so that you have competency programs for new hire, seasoned people, novice nurses, etc. Be willing to accept the fact there's going to be a need for ongoing change or review, and there has to be a method to hold staff accountable. You know, having a competency validation program where staff know no one's going to be held accountable for anything, pretty much is meaningless and does not have any strength. So let's take a look at some planning and documenting competency work. You could change this to 2018 if you want to start planning now for next year. It's hard to believe we're almost halfway through the year. So I've divided this into 2 slides because it has a lot of information. If you look in the left column under competency, you're going to see Donna Wright's 3 domains there, but underneath you also see I've added collaborative work. Some options to verify the method. So for technical, you could do chart review, either self or peer, case studies, critical thinking, etc., and then obviously a column for the date completed. And let's take a look at this next example. Again, we have the 3 domains of competency, and I've added under this one, standing orders initiative. So for technical, it might be something related to validating EMTALA requirements are understood. For critical thinking, it might be chart reviews. For interpersonal, it might be feedback from a team leader or a charge nurse. So again, having these types of worksheets really help you set in stone what your expectation is of staff. This helps you hold staff accountable. And as a staff nurse, it lets me know what I can expect as well as what's going to be expected of me. When you're balancing your requirements for competency, make sure you include the following bullets. The regulatory piece, which we've talked about. Validating qualifications. Promoting consistency in triage. That piece of staff accountability. And making sure everything we do is all working towards improving patient outcomes. When we're looking at ongoing triage competency processes, it's very important that staff understand the expectations you're going to have for ongoing competency validation, what the consequences are going to be if they do not meet those requirements, and what are the different options they can use to demonstrate this competency. Staff love to have options. Let's take a walk through these 6 blocks here when we're talking about triage competency. These are really attributes, or what we call characteristics, that the triage nurse should bring to the table. The ability to make a rapid decision, having a diverse knowledge base, excellent communication, the ability to conduct that brief but focused interview, their ability and willingness to collaborate, and of course that multitasking piece for sure. And I've always liked to recommend adding this to any job requirement or process or competency piece for triage, that they act as a positive customer service representative for the department and they're skilled at prioritization of care. You have to be able to bring both of these elements or attributes to the table for sure. As I mentioned in the beginning, the ENA has updated the position statement for triage qualifications and competency, and I've highlighted just a few elements from this that I wanted to share in our program today. And these are very telling. So let's look at the first one. Years of experience in ED nursing are not a proxy for initial or continued ED triage competency assessment. So we can no longer get away with, oh my gosh, he's been here for 12 years. I've never had a complaint. Certainly he's competent to triage. That doesn't cut it anymore. It's not acceptable. Another example from their 27th statement. Triage competency assessment should not be a one-time event, but rather a fluid, dynamic process with periodic assessment of all nurses who practice this high-risk skill. Now, when you're making your changes and you roll them out to staff to see what these new requirements are going to be for your department, I highly recommend you attach a copy of the position statement from ENA, because this sets the tone. Look, here's the new national practice standard. This is why we're making the change, and this is what the expectation is of everyone who performs triage. And as we work towards closing out the program, I want to go over a little bit more focus on doing retrospective chart reviews. Not everybody has done this. Some places just have not ever thought of doing it as a way to validate triage competency. So let's look at some of these benefits here. It certainly can raise the awareness of the individual nurse when they're going back after the fact to look at a triage note. I have said myself, I've looked at a note from a few days ago, and I'll say to myself, I can't believe I actually wrote this on a patient's chart. I think we've all had those moments. This is the only way to truly validate correct application of whatever triage scoring system you all are using, whether it's ESI or CTAS. It's also a great reality check to assess, are they documenting accurately, appropriately? Are they documenting thoroughly? And certainly it is the best way to validate critical thinking is being applied at triage. Whatever you decide to look at when you do your retrospective chart reviews, I've given you some sample questions to look at. Was the appropriate triage category assigned? Were standing orders initiated? Was the appropriate data collected and documented? Does the triage level actually validate what that nurse wrote in the documentation, or are you looking at the chart going, how'd they come up with that? And is there evidence of a perfusion status of that patient? The next slide that we're looking at is an example from the Sullivan Group's RSQ for Triage Assessment, which is an online tool that can be used to aggregate information when you do retrospective chart reviews. And this chart shows the nurse manager and the nurse educator, depending on the column on the left, whether it was a patient with adult belly pain or a pediatric GI, what percent of the charts that were retrospectively reviewed had those elements across the top documented. So if you look at adult abdominal pain, only 53.5% of the charts documented radiation of pain, but 86.6% did document the patient's breathing status. Only 53% documented when any testing was done or standing orders applied at triage. So there's lots of new ways now with great technology that we can do retrospective chart review. This is another example of things that can be done with retrospective chart review. You see the triage nurse's name on the left. What was the patient's chief complaint? You can look at the name if you have multiple facilities. What was the initial triage assigned? And then after the fact, quarterbacking in slow motion here, do you still agree with that triage level? So if you look at the first example of the adult chest pain, the initial triage level assigned was 3. But after looking at the record, they thought it should have been a 2, and we noticed in the reviewer comments an interpreter needed to be used in that patient, which certainly could have impacted that. So again, this is just an example of a chart that can be pulled when you use web-based tools to do your retrospective chart reviews. You can look at number of records that you review based on the triage level, and in this facility example that I've shown you here, what was interesting is 47% of their patients were a level 2, and 47% of their patients were a level 3 as well. And then you go back more specifically and look at the records in more detail. This next slide shows an example. If we look at pediatric fever, which is the third item down on your left, the most commonly missed element was symptom onset. When did the fever start? And it was not documented 15% of the time. And again, you're not just looking at the triage level, but you're also looking at pieces and elements of documentation that are lacking. So how often does triage competency need to be validated? That's a very common question, and we're going to close with this question. For those of you that are Joint Commission accredited, the competency assessment and performance evaluation is required at least once every 3 years. And the hospital defines the competencies it requires of the staff. Assessment methods are determined by the hospital. Competency has to be done by a suitable person, and again, assessed initially and every 3 years, or more frequently as required by policy or law and regulation. For those of you that have DNV regulatory status, the hospital must continually evaluate performance and competencies of staff, and it must include use of indicators that will objectively measure the staff's ability to perform, and in the third bullet, no less than once per calendar year. Triage is definitely risky business, and one of the things we can do is to minimize risk for our patients. Some closing tips: we need to change the mindset that attending a class or completing an online course or reading a new policy completes triage competency process. We need to educate charge nurses, team leaders, our preceptors on observational real-time methodologies that relate to competency assessment. I do encourage you all to take a look at the updated ENA position statement on triage qualifications and competency. I thank you so much for making time out of your busy days, and I'm going to turn the call back to Jenna and to Brant so we can address your questions.
Thank you very much, Shelley. Great content. And we had a couple questions come in regarding the availability of this content after today's webinar. We are recording today's webinar, and the video of this presentation will be made available on the Sullivan Group website under Resources and Webinars. We will also email this out by early next week, so you can access the video and share it with your colleagues. In addition, while we answer one question here that has come in, if you have additional questions for Shelley, please feel free to drop them in the questions box or in the chat box, and we'd be happy to address those at this time. So Shelley, one question that has come in is regarding more seasoned nurses who have been a part of the emergency room for a long period of time. What kind of obstacles have you run into with working with remediation and continual education of seasoned nurses who might feel they already have this education handled?
It's a really great question, Jenna, and it's a very common question. What I have learned with seasoned staff is that they never really understood ESI, because whoever taught ESI taught what the different levels were, but they didn't use all the content of the handbook. And let's use chest pain as an example, because it's typically this very seasoned nurse that's making a lot of chest pains a level 3 that should be a 2 if you're using ESI. And if you actually go to the handbook and look at the section on chest pain, if the patient has one risk factor for cardiovascular disease, I don't care if they're 20 years old, and they come in with chest pain and you use ESI, that's a level 2 patient. So what I recommend is you have a copy of the version 4 ESI handbook or the most current CTAS if you're using the Canadian scale, and make sure you pull out that particular page from that learning tool and share that with the seasoned nurse and have the discussion. This is what the protocol requires. Here's your triage record. Do you now understand why this patient should have been a level 2? It's not about what you and I think. This is the practice standard for ESI. So if this patient had a bad outcome and your name is on the record as the triage nurse, what are you going to tell the attorney on the stand, your rationale for making this a level 3, when right here in front of us it says the requirement was to make them a level 2? And I think that's the conversation that needs to be had at that season level.
Thank you very much. Another question that has come in is in regards to getting staff involved in the triage competency process. You made comment that validating triage competency isn't just the responsibility of the nurse manager. Can you review some of those strategies and tactics for how to get staff involved and maybe when to get them involved in this process?
Another great question, Jenna. Yes. So what I would start with is your State Board of Nursing. You can get a copy of your State Board Practice Act and scope online, and take out that one page that has the sentence that talks about the nurse is individually responsible to maintain their competency, and use that as the piece of introduction to get them to understand that they're going to be engaged and come up with this requirement for ongoing triage competency. Here's your Board of Nursing requirement. Here's the new practice position statement from ENA. Here are some, we're going to learn about some methods to validate competency. Which of these methods do you think would work well for our group here, and how would you like to see this pan out? And for those of you that are magnets, that have your ED work groups or whatever y'all call them, that would be a great thing to delegate to that group. If you're not in that magnet mode and you use other work groups, develop a team that's interested, but if you do, include a novice nurse with your seasoned nurses, as well as someone who's experienced but's worked elsewhere, so you can bring another set of ears and eyes to the table. And once you teach them the Donna Wright competency, those 3 domains, let them take it from there. What commonly happens, though, is the manager or the educator or sometimes the clinical coordinator has an unrealistic expectation that staff understands what you want them to do. So we're back to filling the knowledge gap. You can't expect realistically for the staff to develop a competency plan for the department if they don't understand the difference between competency, education, and those 3 domains that we talked about. So you can educate them first and then let them, take it from there.
Wonderful tips, Shelley. Thank you so much. And with that, we will wrap up today's webinar. Again, we appreciate everyone's time for tuning in, and we will make this video available for you to share with your colleagues or review at your convenience. If you have any questions about the RSQ platform, either the education or assessment piece for Triage, feel free to reach out to Shelley, Brant, or myself, and we'd be happy to answer any of your questions or get you set up with a preview or demo if that's how you'd like to move forward. Again, thank you so much for your time, and we look forward to sharing this content with you. Everyone have a great afternoon.
Thank you, everyone.